Bonjour, hello, bienvenue tout le monde, welcome everybody. Welcome to today's panel event, Truth and Reconciliation in Practice, Creating a Culturally Safe Environment for Indigenous Community Members, Health Professionals, and Learners. My name is Richard Budgell. I'm an assistant professor in the Department of Family Medicine in the Faculty of Medicine and Health Sciences at McGill University. I'm a Labrador Inuk. I have the very great pleasure of welcoming today Calvin Jacobs, the Indigenous Health Professions Elder in Residence, who will say the Antan Gariwadekwan, the words before all else, or the opening address. Calvin Jacobs is from Ganawage. As a young child, Calvin was introduced to the culture and medicines by his aunt. For the last 25 years, Calvin has worked with traditional elders and medicine people, gaining knowledge about the traditions and cultures of the Haudenosaunee people. He has been working at the Cattery Memorial Hospital Center for the last 37 years as a rehabilitation assistant, 15 years as a language culture coordinator and traditional medicine helper. He is also a faith keeper in the Longhouse of Haudenosaunee. Calvin is a proud father of two, a traditional drummer and singer. He also helps to perform ceremonies and traditional healings. Welcome, Calvin, over to you.
Onagadi wahiga jokwa ozwadon siost ganigani wesa. Onagadi nuamuni zerade ayawas ize skanakoa. Tani awas kawadzira sumhanarze wadagaridege. Tana onagadi nuamuni zerade ona asata humsadat ne wahi dogara nigawanage. Tana ona gadinua wani serdade, dat sida wana warado, ne sungwayatizo, ne gadine hontagari wadekwa angawano headstum. Ona wade wadari wan hodun wizarade doga 10, sayungwa nigura, izigine yonze wade sodara, e toga dina doganeso nigura. Sungwayatizo, ona sato humsadat, ona to nega hawigiga ayuk karawe. Nanigiga ni agyo kwetake. Ona dagwano waratum sego skoni watunya. Ona zai kwat ketchkono kene. Nyao is a sego monka kweni. Ona ardi dajagwatskam. Ne wahine squata natsarayani zemne. Ayo gayo danarastu hagenu gwamsage. Danizani gorawa. Ne zem daim genu waradum sagenu gwamsage togadina toganeswa ni kora. Tanua wani sarda den gwat yordum. Yori wagi adawaga ayum. Zinia do hagezena wadre ne unkwe sua. Tano zenio zi ragwadagwan humsage. Nana yarek agwego skona. Zedowana donyu. Zenio wet dagin hidwayatieri. Ona zingwa dakarida gayato hod. Kajoko gem gana waktum sara. Nega duo nue yari wage zionde watkawe. Nene gana wera dumsara. E toga di na toga nesowa ni gorda. Tano ona ne nuwa ne gayenyu wedege. Uwani sarade. Ayawas ize am dodste. Nega ni go rio skona gasastonsara. Kana guatsario dan again don't guatsara. Negadi aguego, that's the one word out and gayenio where the gazikarong yade, etogadi, naitoganeswa nicora. Dana ona gadinua when he's arade, sungwayatiso. Ona gadi aguego, on the weather we ando, on they do a horde again and the guatni cora. Dano that's the one word out, nesungwayatiso zina hoda, sungwas ani jihumsade, etogadi, naitoganeswa nicora. Ona gadinua when he's arade, what they whether you want hodungo, nyawa ze wagwego, the nyawa sungwayatizo, a togadi, naitogane, so what nicorda, dana ona a to. So I just like to thank you for giving me a little bit of your time this evening. It's so nice to see so many people showing so much interest in the different speakers tonight. I think you're going to really learn quite a bit. We had a meeting about 2 weeks ago with the IHPP, and we were talking about, you know, when you go into a community, how do you, proceed when you're going to work with Indigenous people? Well, one of the things that we do at Gadarizi Desagotizanta Memorial Hospital in Gahnawage is I have a program, traditional medicine program, and whenever we get new staff that come to our hospital, whether it be doctors, nurses, physiotherapists, occupational therapists, even PABs, LPNs, whatever comes through our doors, the first thing that they have to go through is a cultural orientation session with me. And so I get them for about two hours, 2.5 hours. And what I do is I share with them our history and how over time, the movement of our people, how we came to where we are today. And this it helps them to understand that the mind of our people. Because maybe as you might hear and know, Kanyakahaga people, or we call ourselves Mohawk people, we believe that we are a sovereign people. We believe that we have never given up our sovereignty. We have never become a Canadian or a Quebec or US citizen. We continue to believe that we are independent. And so when someone comes to our hospital, we try to make sure they understand this. Because at one time, I remember this happening one time, not in the past, one of staff member, a non-native, came to our hospital to work, and she was working with, it was a woman, she was working with one of our elders, and our elders started talking about his beliefs, about, being a sovereign person, being an Ungwe person, being traditional, living, close to the earth and respecting the earth. And when she was done, she said to him, she says, "What is wrong with you? Canada is a beautiful country. Why don't you just become like the rest of us Canadians?" Well, that didn't seem to go over too well with him. And, he kind of raised a little stink in the hospital because she didn't show him the respect for what he believed, because that's the thing about Indigenous people. We have our beliefs and our ways. And I think it's really important. Before you go and work in any community, you should always try to find out the mind of those people. And so that's just a little lesson that I learned years back. And that's what I share when I meet with people who come through our doors. So I just wanted to share that with you tonight. I'd like to thank you for giving me a little bit of your time. And I'll probably be back at the end of the evening to separate our minds. So nyawa ze wagwegon dana ze wadaraswiahak eto gadi na doganeswa ni gorda dana on eto.
Thank you so much, Calvin. Nyawa. This special bicentennial edition of the Faculty of Medicine and Health Sciences Holmes Lectures was organized by the Indigenous Health Professions Program, Indigenous faculty, and the Indigenous Initiatives Office. This lecture series is named in honor of Andrew F. Holmes, a Montreal General Hospital physician who is one of the 4 co-founders of McGill's Medical School and who was our faculty's first dean from 1854 to 1860. These lectures salute those who are outstanding in the health sciences while celebrating the scholarship that is the backbone of all we do in education, research, and healthcare at McGill. McGill is internationally renowned for the excellence of its medical and health sciences faculty. But I would say to you that the definition of excellence has frequently been culturally exclusive and limited to Western pedagogy and traditions. In this bicentennial year, we've decided to become more inclusive in our vision of excellence. So we have a panel of Indigenous presenters for you, a community health activist, a nurse, and a physician who will talk to us about the current context of Indigenous healthcare and health education and why our universities and institutions must create culturally safe spaces for the Indigenous community members, health professionals, and learners. We hope we'll be able to have a short period after the panelists' presentations for questions. So I would invite you to put your questions in the chat function. And please accept my apologies in advance if we're not able to get to all of your questions. I'd like to thank the Rose Weiselberg Foundation for its generous support, which makes the Holmes Lectures possible. So to introduce to you the first of our excellent panelists, Alex McComber. He is Ganegahaga Bear Clan from the Ganawage territory near Montreal. He is a husband, father, and grandfather. He was a teacher and principal at the Ganawage Survival School from 1978 to 1994 and has worked with the Ganawage School's diabetes prevention program since 1994, currently as a community advisor and researcher. Alex is an assistant professor in the Department of Family Medicine with me. I refer to him as my partner in crime, and he is also a lecturer in the Department of Integrated Studies in Education. His areas of expertise include Indigenous research methodologies, decolonizing strategies, cultural safety, education, community ethics, patient participation in health research, health promotion, community mobilization, personal empowerment, and diabetes prevention. So I will pass it over to my friend and brother, Alex McComber.
Richard, it's a pleasure to be here today and to see everyone. I got tired listening to that introduction. I think I need a nap. Richard also calls me the elder, his elder sometimes. Tongue in cheek there. So it's a pleasure to be here and to have an opportunity to share some thoughts and reflections about this important topic. So to start a bit, I guess, more about my own background and where I'm from. I've grown up in two worlds. The first part of my life was growing up in Brooklyn, New York. My dad was a high steel worker, and our family stuck together and lived together during the first 21 years. And so my education was very American, very Catholic, being brought up, etc. I knew that Cognawaga, now known as Ganawage, was our home, and we went there every summer for the summer to hang out with my grandmother, my aunts and uncles, cousins, etc. And people spoke a different language, and it was a very, very different place. And that's about all that I really knew. In 1976, when I moved back home to Cognawaga and got involved with some substance prevention program for a couple of years, I had the honor to be part of the hundreds of people that started the Ganawage Survival School in 1978, a very sovereign movement, which is the nature of our people as not only as Ganawage, but also as Ganyankahaga. And Calvin alluded to that in his opening words and in the story that he shared. It's a very important aspect to consider, because from where we come, it's this thought that's there. And this is what I started to learn when I returned back home in 1976 to Cognawaga, which became Ganawage, as named by the high school students who started survival school. High school students changing the name of a community. That's sovereign stuff. That's powerful stuff. This is people coming from a place that's grounded and rooted in traditional thinking and ways, even though, as I learned later, that there was this epic of this traumatic epic that took place and continues to take place at this time that changed our thinking. And so my duality comes from growing up in New York and in the United States and in that mind. But then also when I came back to the community, started to learn from community members about who we are and from where we come, and this amazing, beautiful culture with rich, strong, solid values and teachings that just make your heart go big and proud, knowing that we come from this place that our ancestors put into place. So you might think then that my parents were disconnected from the community. As I said, my dad was a high steel worker, well known, and my mom was a housewife. They both spoke the language. My dad more than my mom. And growing up in New York, my mom was certainly the boss of the house and the family, as Ganyankahaga women generally are, and my dad was the protector and the earner of the money to have that roof over our heads and the food on our table. So I need to share a couple of stories to then bring it into the context here. So my mom in the early 1980s had breast cancer, was a survivor, a very militant activist about cancer and about creating opportunities for people who are dealing with cancer to have support. And with a few other people from the community who are also dealing with cancer, they created a cancer support group with the health professionals support at our Cattery Memorial Hospital Center. And these group of people, mainly women, really supported each other through not only the physical but also that very emotional experience of that hard journey. People fell along the way, but people also healed and recovered. And about 25 years after that, my mom also had type 2 diabetes. About 25 years after that or so, the breast cancer returned. And so we went to visit the specialist again. And on the drive over, she was telling me that she decided that she was refusing all treatment. She had gone through the routine the first time around, even did the tamoxifen trials back in that day. But this time she said, you know what? She says, I'm good. She says, I've lived a full life. I'm getting tired. She says, I'm preparing to go. I'm okay with this. And so we went to visit the doctor, and the doctor had an intern or resident with him as well. And so the four of us stood in a circle, the intern across from me. And we had the chance to watch this dialogue between my mom and the doctor, as her doctor was then trying to get her to agree to the treatments, because things like, well, Mrs. McComber, you know you're such a strong woman and you have so much to contribute, and you know this, and you know that. And mom just stood there with her arms crossed and a little smile on her face, just listening to him. I knew that she was listening to what he was saying, because she had that look that if you knew Rita, you knew when she was listening. And through it all, she just kept saying, no, I'm done. No, I'm good. I'm fine with this. And I'm watching the intern teaching this verbal tennis volley go back and forth. And he's got the slightest glimmer and grin on his eye as he's looking at me from time to time, because I'm also looking at him, and I know what she's thinking, etc. But the doctor, the specialist, wasn't quite clued in. Finally, at one point, the doctor turns to me and says, will you please tell your mother that it's so important for her to get on to the cure strategies, the chemo, the radiation, et cetera, et cetera, et cetera. And I looked at my mom, and she just gave me her Rita look, and Calvin's grinning, probably because he knows that look. And I said to the doctor, I says, what makes you think there's anything that I could say that's going to change her mind after everything that she responded to you in that way, in the way that she did? And the intern burst out laughing at that moment in a very respectful way, but he caused me to laugh and my mother to laugh. And the doctor just stood there with his big eyes like this, kind of just not believing what he was hearing, and then just kind of shaking his head. But in that instant, I knew that that young guy standing across from me understood this. Understood this Mohawk elder who knew her life and her journey and her gifts and the decisions that she was making with full knowledge and capacity. So, and he said, well, you know, there's a few months of time, et cetera. And she walked her journey for the next year and a half in a most special and beautiful way, with lots of activity and lots of family and friends, and right up to the very last few days, a full active person who then left in the most beautiful journey that I ever witnessed. We're bumping forward a few years, and around from around 1980, excuse me, around 1980, no, on my dad's 80th birthday. So 1981 or 1991, I guess it was, whatever the year it was, excuse me. He went going for a checkup, and the doctor called him in for a special follow-up, and my mom was asked to come in, and she said, Alex, come with us, let's go. And it's the same specialist, and he had a pancreatic cancer. Yeah, no, colon cancer, sorry. Anyways, and he went on about the treatment and this and that, et cetera, and that it was a good opportunity at this time, that even though he was 80 years old, it was on his birthday, that he was still very healthy and things should be fine with that. And my dad sat there, didn't say a word, quiet. My mom was there, and she was listening, and she was peppering him with all the questions that he knew damn well that she was going to be asking him, because he had to deal with Rita for many, many years. And no doctor ever left the room without Rita being satisfied with all the answers that she had to know. so that she could then make her decisions. And so she listened, and on behalf of my dad, asked those questions so that on the ride home, and when we get home, he's going to start pummeling her with all these questions that she's going to be prepared for that. We walked out of that specialist office and the door closed, and my dad was in front of us, and he turned around to the two of us and he said, "There's nothing wrong with me." And at that moment, I understood that he was not coming from a place of fear. He was not coming from a place of ignoring the reality, but that in his mind, that he was in good health, that there was nothing wrong with him, that he was in control. And he went through the routine. He had to get injections for, I think it was a couple of years. After a year or so, the specialist that he had to go and see, and because they had to do tests and get the shots and all, said, "Mr. McComber, I don't know why you're coming here, because all your numbers are just perfect. They're gone. It's gone. It's not there." And sure enough, the follow-up test proved that. And so I share these two stories of my parents, showing that even though what I said earlier, that they may seem to have been disconnected from the community and culture in a way, because we lived away and grew up Catholic and American, et cetera, I came to realize and understand how grounded they were in understanding who they are as human beings, and that it comes from a Ganyankahaga Haudenosaunee perspective. The Haudenosaunee is the people of the Longhouse. That's who we're part of as the Ganyankahaga. And that this is part of that rich foundation and philosophy and way of knowing and understanding of who we are and from where we come. And I recognized that you don't have to be a card-carrying member of a society. You don't have to put a label on you and say that I'm a traditionalist, or I'm a warrior, or I'm an Indian, whatever term you want to be. But knowing inside who you are and how you live your life and how you your journey is what counts and what's important. And in the context here today, I think that Rita and Alex showed us, my brother and me, and our kids and our wives and the people of the community, that this is how we're supposed to live our life. That we have a handle on this, that we're in control of all this. So when we then talk about health systems and the current system, that as the way things are set up, it's cool if people are going there and they understand about contemporary health, they understand monolithic systems, they understand the way that the games are played and going through the system. And that because we have this connection to our culture, to our roots, to the words that Calvin shared at the very beginning for us, that's those things are still there, those teachings are still there, that medicine is still there, and that health professionals, students, faculty members need to know and understand this is from where we come. Our own people are also on a return journey of relearning that and getting that strong in us again, so that as the generations will continue moving forward, we'll have increasingly strong generations of people who can walk into places with confidence, with knowledge, and with information, and be able to deal with the way the system is constructed of taking care of its own. And its own is in fact created by people over 150 years ago who came from very biased, racial, paternalistic, and misogynistic backgrounds. But that little story here is part of sharing some awareness. And that becomes the first step in a cultural safety journey that reconciliation speaks to, that you need to go on. That the non-Indigenous people, health professionals, educators, faculty members who are teaching students, and teachers inside the schools who want to be doctors, want to be nurses, health professionals, educators, social workers, need to learn that, and also need to learn, and I think that my other colleagues speaking will speak of this reign of terror that we've experienced of assimilation, colonization, and genocide, which is still ongoing, and that you need to understand that it's impacted upon us, and that nevertheless we still intend to return to that place where Rita and Alec come from, that they can stand up and not only work within the system, but also know themselves and heal themselves from within, working with a team of people that support them. So I thank you very much for your time and attention this afternoon, and I look forward to my colleagues' presentations next, as I'm sure you'll enjoy. Go on.
Thank you, Nyawa, Alex. I'm sure that I'm not the only person here who is very deeply touched by what you've just told us. I adore hearing people talk about their parents because it's where we're from, and I know that you've heard me talk about my parents. That's such an excellent orientation for all of us in terms of the root of cultural safety and the root of patient-centered care too, talking about your parents and their health issues and receiving the kind of care that they wanted, that they directed. We're going to go to the next presenter now. So our next panelist is Glenda Sandy. Ms. Sandy will do her presentation for us via recorded video because where she is right now in northern Manitoba, the community has quite poor internet connectivity that we couldn't really count on. And just to say, that's a common systemic issue in Indigenous and remote communities. She will dial into this session by phone, so she will be able to respond to questions later on. Glenda Sandy is a RN, Master's of Science, and is an Naskapi Cree from Kawawa-Chikamash, Quebec. Her master's in community health was on an exploration of Naskapi Miyupmatsiyun, in Naskapi meaning of health, a definition of health. She is a nurse advisor for public health with the Nunavik Regional Board of Health and Social Services, and she is an Indigenous nursing consultant for McGill's Ingram School of Nursing. So we'll turn it over to the video that was previously recorded with Glenda Sandy.
Glenda Sandy, Louis-West, Mojabin College, Quebec, across Lake Manitoba, Quebec Cree Nation. Maidan Gaden, Maidan Gajuishan Goyan, that you wait man Genia Schwaterman. Mamu, that you do Sanot, that you do Mew Bichach, huge, what the estimate, the Asian, Hello, everyone. My name is Glenda Sandy. Very happy to be joining you today. I'm from the Naskapi Nation of Kawachikamach, Naskapi Cree from the Kawachikamach Cree Nation in Manitoba. And I just wanted to start off with acknowledging where I'm coming to you from, which is the territory of the Huon-Wendat Nation, Quebec City. The title of my presentation today is Dabul Nishtam, the truth first, and that's the translation of what that means, and how we can have truth and reconciliation in practice. I'm going to go over sort of a little bit of just a little bit of history, but I would like to put in more of how I view reconciliation based on my experience as a nurse. I've been a nurse for almost 20 years, working in a variety of Indigenous and non-Indigenous settings, and what my views are on reconciliation and how we can move towards that. Just a little bit on the Indian Act. So in 1920, the amendments that were made to the Indian Act made it mandatory for children 7 to 16 to attend these schools. And in 1933, parents were forced to give up their rights as parents and transfer legal guardianship to the principals of these schools. And so there were 139 government mandated church administered schools that were active in Canada. And this is just a number that came out from the Indian Residential School Settlement records. There were probably more that were run by other outside of the government type of institutions that ran other schools. Children were taken away from their families, and again, the goal was to kill the Indian in the child, but really breaking that connection to their communities, to their parents, to their families. A lot of the children actually were taken away far from their homes, and that was a strategic move to alienate children from families, but their families couldn't go and get their children or couldn't go see them. The picture on the bottom, you'll see the 1944 pastoral visit. That was my grandfather who attended residential school, his group. My grandfather, being from northern Manitoba, was sent to a residential school in southern Saskatchewan. So the difference, the distance where he was taken away. With that, there have been a lot of inquiries, commissions that have happened for a number of years. And that's sort of what led to the title of this presentation of The Truth First. Because the way I see it is that we have done things that that were accepted, not accepted, but was sort of the right way in terms of how the Western world or the Westernized view of how things should be done have been done. So with the Commission, Royal Commission of Aboriginal People in 1996, we had the Truth and Reconciliation Commission in 2015, the VA Commission in 2019 in Quebec specifically, Missing Murdered Indigenous Women and Girls Inquiry in 2020. All of those came out with the truth. And with that truth came recommendations on how we can work on reconciliation. All of that is there. But it just seems that the truth is sort of being denied or held in a certain spot, not being able to move forward because there are debates surrounding over what is constituted as the truth. Even with all of that, even with the things that have happened in the last 25 years or so, to get the truth out, we still see oftentimes examples in health specifically of stories and things that we hear of how the treatment of Indigenous peoples is still very much very almost scandalous. Because if the tables were turned, well, then this would have probably been a bigger issue that would have been dealt with earlier. We have Brian Sinclair in 2008. He was a homeless double amputee that was sent to emerge by his family doctor because he was known to have recurrent bladder infection. He sat in a Winnipeg emergency room 36 hours and eventually died because staff thought that he was drunk when in fact he had started becoming septic. And nobody really went in to check on how he was doing while he was waiting. And by the time they found him, he had already died. All of that to say, for me as a nurse, with having had gone ahead in my schooling, I still think that there is that denial of the truth. That all of that, it's there. It's in black and white. It's testimonies, it's stories, it's examples like this that are happening, and yet the truth being denied. In this, for my experience as a student, as a master's student, starting to go into research, there's been just so much emphasis placed on Western views of research and what that means. This is an image that I found from a paper from the University of Western Ontario. It's unpublished, but I found this figure and I thought this was a good example of how there are two very different views that I have. So this is sort of the models that would be used in sort of the westernized way of performing research, doing research. So there's a lot of emphasis placed on models and how that, in doing research, drawing up these models, these examples of really trying to condense information that's being collected. And this, this picture, yes, it tells a story of the roots of colonialism, the Indian Act, residential schools, plus the racism and discrimination that we face on a daily basis has blocks or creates barriers in accessing healthcare, support systems, a social network that makes sense, because there isn't a cultural continuity, and that affects the social determinants of health that we see here: the income, education, rates of substance use, employment, smoking, all of that. And that just sort of, it gives sort of a one-sided, I think, view of the way I view health, the way I view the health system. As part of my master's program, what I did was I sort of took an Indigenous approach to figuring out what health meant in the Scappi, because there wasn't a word for it in Scappi. There wasn't, something that for us, health is, literally the literal translation is sickness, and that's not, I don't think, what health is. What what for as a community, what constitutes the absence of illness isn't what constitutes health. There's so much more than that, and that's where I drew upon my own history and the way I was taught my values, and the culture, the Naskapi culture, because I grew up in Northern Quebec. I grew up in the Naskapi culture, immersed in that. And for me, this picture gives that one-sided view. When, if we look at this picture, this was a picture that was drawn up by a person for another project, and I borrowed it because it just, for me, there's no words, there's just images, and that speaks much more to me than the previous photo. So this is a picture of two rivers, and the way it was described to me is that the lower river, the river on the bottom, that flows into the larger river, is sort of the indigenous worldview, and this is what I would. This is how I grew up. This is what I've seen growing up. Growing up on the land, learning about my culture, the foods that we eat, the medicines that we use. I started off in that river, and when I was a teenager, that part of my education was cut short because I had to sort of join the other river, which is more the Western worldview or the Western ways of doing things, to be able to walk in that world. And so for me, I'm kind of like in the middle, that little island of knowing that the way the two rivers flow. I've learned to paddle in both rivers. I've learned to, be able to maintain a balance. But in terms of approaching reconciliation, the thing that we need to do is to join those two rivers into one by taking in the flow, the strength, and the waves that come with it, to work on that together. And right now, the way I see it is the truth is sort of being blocked up. It's dammed up at the upper river, further, downstream, where there's still debates on what will be considered as the truth, what will be used as a way to move forward in reconciliation. You can't pick and choose pieces of that. And right now there's a dam, there's a huge dam that's there. And what I'm trying to do is branch by branch, remove the dam that is built up and to clear the river, to clear the way for both rivers to flow together. But it's going to take much more than that. It's going to take more people, more allies to be able to do that. And I think the understanding has to be there of how important it is for Indigenous health, for reconciliation, that at this point, we need to bring both truths. So that's, I think a lot of it might speak to I've seen approach of working together. And so, one person cannot dismantle the dam. We're going to need more people, more efforts being made. And I think that will happen once, the truth is acknowledged for what it is. And so the difference between this image, I will, always be on that lower level, the lower river, with what I've known, what I've learned. And although that's been cut short, I can always go back and paddle along that river and learn what I was not able to learn at a younger age. I can still go back and reclaim what was lost because I was learning to paddle in that other river. And there's a way to do that. There is totally a way to do that. The thing is it's sort of stuck on, what is the truth? Just because the truth isn't how you would view it doesn't make it less true. And so for me, reconciliation is part of that is to acknowledge the past, to learn the true history. There are so many documents that are there to be able to learn of what went on before, things that have not made it into the history books that are being used to teach. A lot of the research from before has diluted by such a Western way of viewing things, but the richness of the Indigenous knowledge has not made it through, did not sift through, because it was probably compartmentalized into sort of how the Western view of science wants it to look. And so a lot of the richness that comes from knowledge keepers from the communities is lost in this dilution process. But as I said, there are a lot of documents that are out there that would give a better understanding of the realities that we are faced with and that impact us every day. As clinicians, I think it's important as well to be aware of the ongoing realities that impact Indigenous people, and that's the programs that are there to learn about them. One of the things that I often really frustrates me is the non-insured health benefits program. that there are delays in treatment, starting treatment, because of the the red tape and the bureaucratic process that are there at Indigenous Services Canada. They're the ones that manage this program, and the NIHB is a program that the would be the program that covers dental health, medical equipment, prescriptions, the glasses. All of those programs are under NIHB. And what happens is, because there sometimes the treatment options that become more and more available, the newer and newer medications that are becoming available, often aren't covered under NIHB, and they have to go through a process of going through a request for an exception to these medications, and that can result in treatment delays because of the paperwork that's involved to make sure that it's covered, that the cost of medication is covered. And I think it would be important for clinicians to understand how this works, and maybe have something in place to be proactive before you see somebody. If this is something that's going to be prescribed, well, be mindful that there are going to be hurdles for the Indigenous patient to go through in getting the medication. It's not simply writing a prescription and they'll go to the pharmacy. Jordan's Principle is another program that clinicians, I think, should be more aware of, and how that works. Again, it's under Indigenous Services Canada that's administering this, but I've gone through it myself as a parent, and it can be, although it's easy to access, it also can be very difficult to access. And the reason I say that is because it's not only the parent that requests, that there has to be sort of a backup of, if it's coming from a teacher, from a social worker, from a nurse. Even though I am a nurse, I had to sort of go to another nurse to be able to get through that process of getting services for my son. So it's still, the program is there to help children access health services and other, mental health, education, all of those supports. But they do need to be, they need to have that support from a healthcare professional to make it easier to get to. Joyce's Principle is something that also is in the process of, we're trying to adopt that. Where we want the principle itself demands that all Indigenous people have equal rights to physical and mental health. It wasn't adopted at the National Assembly because of that argument over semantics of systemic racism. Those two words is what blocked it. But other organizations, other faculty, other universities have gone ahead to adopt it, and I think that's part of that dismantling the dam that I was talking about before. Is we're not going to wait for somebody to come in and remove everything. I think it's going to take a collective to bring the truth forward. I think other ways that we can approach reconciliation is to recognize the strengths and experiences of different people in different communities. And as clinicians or people who have gone further in their education, your place in the community. What I say often is, when I go home, when I'm on the land, the letters after my name don't make a difference at all. It doesn't matter how many letters come after my name, how many degrees or certificates or whatever I've accumulated on the land, all that means nothing, because it's a different kind of knowledge that's going to get me through, that's going to help me survive on the land, and that cannot be learned. So I think as clinicians going into communities, maybe research, so for researchers to know your place in the community and to know that you are there to get something that will bring something back to that community. So we're not going to be taking out stuff for our own, I guess, place in academia, for example. The work that I did for my master's, I haven't gone ahead to get it published. I've been, approached that I should get it published, but it's not my, it's not mine to take for my own, to take credit for. It's something that belongs to the community, and it's something that I would want to work with the community in getting that forward. And I have to get their permission to do so, because the information that I got for my paper doesn't belong to me. It belongs to my community. And I did that with the objective that it would help my community in designing programs, for example, that are more culturally relevant in their definition of health. And so, I think in research, that's something else that needs to be taken into consideration. Of that, researchers that go into communities aren't they need to collaborate with the community first and foremost. Make sure that it is reciprocal. That yes, you want to find out something, but that this something has to be something that's useful to the community, and not just done just for your own professional pursuits. Another thing is to make academic space accessible for knowledge keepers, acknowledging and respecting their lived experience and how that lived experience can be better for the academic space, because it allows another view of the world. Often, I think I've seen in, let's say, job postings or whatever, that they have to have attained a minimum level of education. Well, you're taking away a whole rich unity. You're excluding a very rich experience there in making these requirements, or imposing these requirements on in the academic spaces or faculties or programs. That there has to be space for the knowledge keepers, and the knowledge that they have has been acquired through their lived experience. That I think we need to be mindful of and respect. And then, I think just in summarizing all this, I think there has to be sort of a self-reflection on the acquisition of your own knowledge. Who was telling the story? How was it told? To go back and see, to reflect on that, and see if there was a one-sided view that put more, placed more priority on a westernized view versus the Indigenous view. So really reflecting on who is telling that story, where is that information coming from, and how was it told, what narrative was shared. And with that, I think just these few things to start off with, I think really try and dismantle that dam and really make that truth come out. Because without the truth, we can't have reconciliation. Unless that's acknowledged, there can't be any real change. You have to acknowledge the truth for what it is for reconciliation to happen. And this last picture is the picture that I showed you of my grandfather's class. It's my grandfather on the left and my son on the right. My son had trapped his first rabbit. And you can, see the difference in their faces. That he was my grandfather was in residential school, wasn't smiling. He was 6 or 7 at the time. My son was the same age, and this is sort of what I use to guide my my own learning journey in this lifetime. To look back and not forget where I came from, my own family history, and not to forget what I am doing this work for. That I'm trying to make the world better, a better place for my children, because they don't deserve to be burdened with the past or carrying that forward. We want them to flourish, and I think that for me is what I found to be my objective in the work that I do. And with that, thank you, Janishka McNell. Thank you so much for your.
Thank you very much, Glenda. I think the point about whose truth in the question of truth and reconciliation is incredibly pertinent to all of us. Whose truth are we listening to, and who has the opportunity to say this is their truth? And again, I really appreciate your presentation. I'm familiar with a bit of the territory that you're talking about. Our hometowns are not that far apart. I grew up in Labrador City, which is a couple hundred kilometers from Kawachikamash and Shefferville. So I'm familiar with that territory, and it's been a great blessing to me to have been able to be there. So thank you very much. We're going to move on to our next presenter now, who's Elaine Kilabuk. Elaine is an Inuk physician from Pangnirtung, Nunavut. She graduated from McGill's Medical School in 2015 and completed her general internal medicine training and fellowship in Ottawa. She currently works at the Ottawa Hospital in Ottawa and also at the Kihiktani General Hospital in Iqaluit, Nunavut. She has a special interest in point of care ultrasound, social determinants of health, and Indigenous health. She is also the founder of an award for Indigenous students in the health sciences field at McGill, the Elaine Kilabuk Inuit and Indigenous Health Professions Award. So I would pass the floor over to Dr. Kilabuk. Welcome.
Unaku to everyone. Good evening. As Richard said, I'm Elaine Kilabuk. I want to just start off by thanking Alex and Glenda for sharing their very powerful talks and sharing their experiences. I am, there you go. So I'm originally from Pangerton, Nunavut. So Nunavut is used to be part of Northwest Territories, and it became its own territory in 1999. And Nunavut means our land, and it's a self-governed Inuit government. And then this was really just kind of to show how I'm sure, as many people know, Indigenous peoples are all across Canada, and that there's very different types. And it really, I think, highlights that we're very different, even amongst different Inuit in terms of dialects, depending on what area of Nunavut you're from, and same thing, even say from Nunavik. So this is a picture of me in Pangerton. So I was born there, and then we moved to the United States when I was 5. My mom is American, and we would travel during middle school and high school back up to Pangerton and Iqaluit. And it was really in those times where we got to do all the things I love to experience and learn more about my culture in terms of what it meant to be out on the land, to go camping, to go hunting, to really learn those and relearn those skills of safety. And it was really also in those times that actually led me into why I even went into medicine. It was, such a sharp contrast of the types of food options and the pricing of things, and particularly healthcare. That was a really big motivator for me, just to see such the big discrepancy between healthcare, particularly in my hometown Pangerton compared to in the United States. So for people who might not be aware, Nunavut is so Iqaluit Kikatani is the hospital, the main hospital for the region, and that's where all the family doctors and specialists who come up from Ottawa come, and then the towns are the smaller towns are all by plane. There's no roads between them. You have to fly, and there's just nursing stations. So there's nurses who anywhere between 1 to 8 nurses with variable experiences. So it was, I think the most memorable time for me was my grandmother she was having COPD, so chronic obstructive pulmonary disease exacerbation. And this is while we were in Pangerton, and the time that it took to recognize what it was, the time that it took to talk with the physician, and the time to the decision that it made to fly her down was hours. And so as someone can imagine, if you're coming from a healthcare field, sometimes these people don't have hours. And so really it's that for me was the reason even why I went into medicine, was with the hope and the plan to come back and give back to the community and provide a service where we might not be as accessible. So I went into general internal medicine, and I went to McGill Medical School, and I was very fortunate that McGill at the time had spots for Inuit from Nunavut. And I did my internal medicine residency in Ottawa and my fellowship in Ottawa. And I'm still early on in my practice. I'm going into my second year. I currently work in Haluit and as a general internist, and then also in Ottawa as well. And this is just a picture from Parrington. Actually, it would have been about 5 hours from Pang in August, us trying to go caribou hunting, unsuccessful on the caribou. But again, it was, it's these experiences that really remind me, and kind of learn again every time I go out, more about my culture and the importance of your connection to the land and how your life is dictated by the land. So I think, a big part of what's been said before is when we talk about different truths, or even the start of reconciliation, really it's an awareness of what has happened, and that's the education component. And so for me, when I think about my special interest of social determinants of health, a big part of what has led to these social determinants of health is going to be the history. So in terms of periods of contact, so we had the whalers that went in the Davis Strait. You have the Arctic fox fur trade, and really it's in these times where you have such a shift in the traditional Inuit ways, where they were nomadic hunters that followed around the marine and land mammals, to really a shift where you have contact and you're starting to have trade for guns and ammunition and other goods, and the populations might be a bit more spread out. And then obviously with these contacts, you're having disease, which is going to impact the population of Inuit. And for the 1930-1940, the government assigned DIS numbers to Inuit. 1941 is when we became part of the census. 1945, there was annual screening of Inuit for TB. And this is where they were starting to have ships, the Gordie Howe ships, and then even in Southern Ontario sanitariums, where people would be treated and isolated for tuberculosis. And what's really unfortunate, and it's very similar parallels, unfortunately, to residential schools, is that a lot of times, unfortunately, when people passed away, their remains were not sent back and reconnected with their families, or news wasn't given to their families that their loved ones have passed away. So a lot of hidden remains in that sense. 1950 was when first able to vote in the federal elections. And then really in the 1950s, much and later on too, you start having these forced relocations in the high Arctic communities. So again, like I said, you had this, people were very nomadic. They didn't have these large communities, and it was through the government and RCMP and through the Christian missionaries where you were having forced relocation and creating of towns that weren't necessarily how the traditional way would be. And it's interesting because now we're, finally the towns are starting to, as they reclaim their names, their original Inuktitut names versus the government names that were given to them. The 1956, approximately 10% of Canadian Inuit were confined to TB sanitariums. And really it was in the 1960s where, again, Glenda talked about residential schools and the impact that it had. And it's been, my father was a residential school survivor, and it's been very enlightening and educational for me and emotional to hear about the traumas that he had and what it means for him and how it affects his life and how it affects, our family and what it means for them. So I have to say it's been very enlightening and educational and emotional journey, not just for him, but to be able to share it with our family as well. And we really, it sheds light into how, you know, generational traumas really do occur and how people deal with these types of trauma. You know, when someone is really trying to take away your culture and your identity, and a big part of that too is going to be, you know, creating such a disconnect within your own family, because he went out to residential school in Manitoba, and then to come back, you know, he at that time he would learned English when my grandparents didn't speak English. So there was such just a disconnect in being able to even have a conversation with your parents at that time, and not knowing, you know, how they're doing, what they would have done, anything like that. So, and then he, you know, briefly also talked about the money, giving people money for them to go to residential schools, and how much it was, which is very little. But again, it's been very educational and emotional to hear about those traumas. So now, at least kind of when I talk about on a complete shift, is going to be my, you know, my personal interest within the medical field, social determinants of health, really, because a lot of what I treat is going to be chronic diseases. So high blood pressure, obesity, diabetes, and really to understand, you know, why do we have these diseases? It's taking a look back at starting off with the history, which is why I did that, because I think these, you know, all of these points in history really highlight that these different encounters that were happening, in most of these cases, the purpose of these encounters were colonization, were forced relocation, were residential schools. And it's kind of through that where you're having the acculturation, where you're having these cultural modifications, where you're having these establishments of large urban centers. You're transitioning from traditional fishing and hunting to southern imported food. You're having a steep increase in tobacco and an increase in sedentary lifestyle. And for me, I believe that it's the saddened history of colonization that has led to these social determinants of health, which then downstream contributes to what we're seeing today of these chronic diseases. And so this is just a slide from ITK, where, and this is from 2018, but I really wanted to highlight the inequities between Inuit and Canadians, and I know that this is not just specific to Inuit, it's to Indigenous peoples across Canada as well. I talk about Inuit just from Nunavut because that's what I know. And so I think the ones that I'll definitely point out, so 52% of Inuit live in crowded homes compared to 9% of all Canadians live in crowded homes. And so this really plays a part where we think about diseases that are still prevalent, very much so in the north, it's going to be tuberculosis. And so you can imagine that if a lot of people live in a home, so more than one person per room, tuberculosis is something where it can be active problem, and in terms of outbreaks, that is an issue. 34% of Inuit have a high school diploma compared to 86% have a high school diploma. And then something that plays a really big part is going to be, depending on someone's education, really it's going to correlate in terms of what job that you have, which will dictate what income that you have as well. And you'll find a lot of these social determinants of health are interconnected, and anyone can be affected either upstream or downstream from this. One that's striking is going to be the 70% of Inuit households are food insecure compared to 8% compared to all Canadians. And I think something that even that's going on now that's very relevant is the Iqaluit water crisis. So there were petroleum hydrocarbons found in the water source here in Iqaluit, October 12th, and it is still in the state of emergency. So we do not have regular drinking water. Water is going to be, there was water that was brought up from the armed forces about a week ago. So there's a delay in time, accessible water being given. We do have the river that's here, but again, that has to be boiled. And then even with the grocery stores, there was an increase in the price when this happened. So I think just even in this situation that's currently ongoing and that's very relevant, it really just kind of highlights how just regular drinking water might not be as accessible, but even if the only source you can get it from is going to be the grocery store, they've increased their prices. But the problem is that if you have multiple people who live in the house with you and your income is not very high, how that can be very difficult to access. And then projected life expectancy is 10 years less. So these are like I said, all the kind of social determinants of health for Inuit health specifically. And then this is something where it might just be relevant because I imagine at some point, wherever everyone is, you will come across Indigenous peoples, but this is more particularly safe for the Nunavut and Nunavik region, particularly people who live in Montreal. And it's really just to highlight how healthcare access can be very difficult. Where you have different hubs for different communities, and then you can see how obviously a more isolated someone is, they have to fly to Iqaluit and then they fly down to Ottawa. So again, with all of this, it's access to care as well as the big social determinants of health. I talked about the Inuit history, various modes of Inuit acculturation through different types of trade, economy, and over these periods of contact. And you can see how Inuit culture has changed, and now we're left with various traumas which dictate our present environment. So now we're in this dichotomy of recognition of the wrongdoings and continued celebration and resilience of Inuit. So, where are we now? What can we do now as clinicians? And so it's, the road to reconciliation. So what is reconciliation? As everyone talked about, I think a really big step is awareness of the past. And that's why I took the time to explain the history specifically for Inuit and Nunavut, and explaining kind of where, how it's led to our chronic disease problem. Acknowledgement of the harm that's been inflicted, atonement for causes, and action to change behavior. And it really has to be with everyone. It is not just the onus on us as Indigenous people. It's everyone to have the proactiveness and interest to learn and to ask questions. So part of that is going to be this continuum, and this is the next two slides are going to be from a conference that was done by Darlene Kitty on cultural competency, which I thought were very helpful in the sense of understanding, where do we go from here? How do we even start? So we have this idea of a learning continuum, and I think everyone here, including myself, is on this spectrum. We're all learning and we're all trying to become competent in whatever culture of people that we're interacting with. So when we think of cultural awareness, it's the acknowledgement of difference, the first step in understanding cultural differences, and involves observing those differences. So really it focuses on like myself and another. So I think even, by being here, that's a sign, I would say, of having some sense of cultural awareness. And then now, if, depending as you move forward, cultural sensitivity. So this is where you have behaviors that are considered polite and respectable by the person of the culture. But again, it still focuses on myself and another. And then as we move on, that's where we have cultural competency. And that's where we're having a set of behaviors and attitudes and policies that come together to enable effective work in cross-cultural situations. And really, it's having the capacity to function effectively within the context of cultural beliefs, behaviors, and needs presented by consumers in their communities. And then the hope, obviously, is going to be cultural safety, is that we get into a cultural safe medical environment. And what this is, it's an outcome of culturally competent care. And it results in an environment free of racism where people feel safe when receiving healthcare. And I think, you know, something in my mind is that if we're not providing culturally safe care, then I don't think we're providing adequate care for the population that we're providing. And like I said, everyone is on a different spectrum and where they are in this process. And it's about being interested in getting the education and asking those difficult questions for all of us to be able to get to a culturally safe environment. And I think a part of that, and I'll just give some kind of tidbits, you know, when I think about my own community and my own culture, which I'm sure are very similar themes when you go into different communities, but you know, for us, it's a big importance on community and family, respecting your parents, respecting your elders, and a big part is giving back to the community, and that's kind of the reason why you do things. And then really there is a big difference between Western medicine and traditional medicine. You know, we come from a mindset of you know, what is the disease model, what is the medical training, the scientific reason to do things. And I think from a traditional medicine standpoint, you have that physical, apart from the physical, you have that mental, emotional, and spiritual kind of metaphysical well-being that really plays a part into someone's care. And I think the biggest thing is, you know, is recognizing that and acknowledging it, and not being judgmental when someone brings that up. It's being open. It's being open to that. Because particularly for me, I find a lot of my patients, a big part is going to be, you know, being out on the land and what it means to have that connection to the land and what it means to have that connection to the food as well, and how that really plays a big part into their diet. And so I really try to work with them to figure out how we can, instead of trying to take away their country food, it's really trying to incorporate it back into their diet if it's possible. This is again from a great side from the RPC Indigenous Health Educational Series, and I thought this was great to really kind of, you know, highlight how, you know, if we can, and taking the time to do it, how do we include these mental, emotional, and spiritual aspects into our care, particularly say for an Indigenous patient. And a big part is really considering these social cultural contexts of someone. So what is their demographics? And I think, you know, I can share just a few, depending on the time, but share just a few instances where I feel like us as a system have failed. Particularly say for patients who come down to the Ottawa hospital where they don't have the education component or looked into the education component of geography and what it means that not everyone who comes down from Iqaluit lives in Iqaluit. It's just that that's the hub to get down there. So what does that mean in terms of from things that we can offer? Well, a big part is going to be if somebody is from a small community, they only have nurses that are there. So you can't give IV antibiotics or you can't have a CAD pump, things like that. But it's the education that's needed. And that's more education that's needed at the, you know, the center that you're caring for these patients when you discharge them back home. I see it even for people, physicians who unfortunately come up here as well, not having an understanding of the history or the, again, geography, that you can't just say, go, come back tomorrow, when they live via flight an hour and a half away. But again, that's something where if you had that education to know the population and where they're from, how that would be a bit more, a bit easier, hopefully. And then,
Like, I wonder if we could conclude shortly. The questions are piling in because your presentation, the others have been so fascinating. So if we could leave a little bit of time for questions, that would be great.
oh yeah. Okay, sounds good. Can I just finish the last slide?
Yep.
There we go. Yeah. So I think my biggest things I would say, what are our barriers to culturally safe care and what do we do about it? So as it's kind of echoing a lot of the same, I think, values and themes that we briefly talked about is the lack of knowledge. And so really it's trying to be proactive in trying to obtain that knowledge, and the onus is on you as a provider. Observe, listen, be patient, be silent, avoiding stereotypes and making assumptions and prejudice against people. And like I said, I think just being open and being open to the knowledge and asking those questions, asking those difficult questions, and then always being respectful of the culture, traditions, and the people in front of you. So thank you. Sorry for going over time.
No problem. Thank you so much, McComber. I love how everyone today has spoken about history and family, because that is for all of us where we come from, and that is as Indigenous people where we are rooted. So that's a very common theme. And I love how you used maps, because I frequently use maps in presentations as well. It's part of our worldview, I think, to use maps to show the landmass that we occupy. My colleague, Alex Allard-Gray, is going to share some questions with us. We will not have time to answer all the questions, I don't think, but Alex, can you select some questions, and we will pass them on to the panel or to individual panel members if they've been identified in the question.
Absolutely. Thank you, Richard. So the first question we have here is an open one, and it says, in Western academic world, publication is the way to go, and everything else is dismissed. How can McGill include Indigenous ways of knowing in formats that are not Western publication? And is there a project or other efforts to preserve spoken knowledge and histories?
Who would like to jump in on that? Professor McComber?
I'm still trying to wrap my head around the question. That was a big question.
It is a big question. Alex, do you want to repeat it quickly?
Absolutely.
Morales?
So in the Western academic world, publication is the way to go, and everything else is dismissed. Oh, it's a two-parter. I'll read the first part. How can McGill include Indigenous ways of knowing in formats that are not Western publication?
I think that we're beginning to have the experiences in the academy of partnerships between community and the academy in doing work. So particularly at Department of Family Medicine, PRAM, Participatory Research at McGill, is housed there. And the Kahnawake Schools Diabetes Prevention Program has been in a 25, 26, 27-year partnership. And the community controls this project. The grassroots people of the community control this project. It's not a band council, not a health director sanctioned thing. So it's the practice of the academy taking the risks from that Western view of working with the academy and coming to the table with transparency and openness that all the all the information can come together for projects, for creating, for planning, for implementing, for the evaluation of things, etc. Same thing with creating the curricula for courses. It's got to be joint efforts. It has to be that the people from community have the say, have that input and say into how things work and how things go, and for the academy to listen and to take time to listen in the teachings that come from the elders and the knowledge keepers who may not even have high school diplomas under their belt, but who have doctorates in the world of Indigenous knowledge, and to listen to them as to how things get done in respectful ways, where you cover the things that you need to cover in good ways, and that the outcomes are in fact for the benefit of the community and the children and future generations.
Thank you. And I understand Glenda Sandy is with us by phone. I wonder if she had an opinion on that question.
Well, yeah. Hi, everyone.
Hey.
I would, go along with what Alex said about the recognition and acknowledgement of Indigenous ways of knowing, the traditional knowledge that a lot of our elders have, and not to rely solely on bringing in people that have letters after their name. I've mentioned this before, with what I know I got from the way I grew up, with the values that were taught to me, learning on the land, and anything I've achieved, since, in my adult years, doesn't really do anything for me on the land. It won't. I think that we need to really place more focus on the person and not the degrees that they maybe may not have. As you said, sometimes they may not even have high school, but they have this wealth, this library of knowledge with them that I think we really need to work hard on preserving, because a lot of our elders are going and leaving for the spirit world very fast, and libraries are being lost. We need to really try to harness that knowledge and not rely totally on Western ways of doing things.
Dr. Kilabuk, an opinion on that question?
Yeah, I agree with the sentiment that Alex and Glenda were saying, that a really big part is who is writing the history, and who is telling the history and to whom. And I think that it should come from the people, right? So, and it's hard to say who's going to be the best person to do that, but if it comes from the people, comes from the elders, the community, it really then will highlight what is the history that they want people to know, that affected them. And I think schools, at least in kind of medical schools, at least I can speak to the University of Ottawa. I know that there is some interest in providing this education around particularly like Inuit health, and the history. And particularly, I usually give a talk there through about TB, and it's looking kind of through the lens of TB history, and how it pertains to Inuit history and how it's so representative of it. But again, it's kind of really echoes, like I had mentioned, it has to come from the people, so they know what's going to be pertinent to them, and in the history that should be known.
Thank you, Dr. Mink. Well, we got through one question, but the presentations were so fascinating and touching, I think, for all of the participants today. We've had sometimes close to 300 people in the audience here. So, and we've been getting very, very positive and interested comments from all of those participants. But I don't want to keep you over time. So I'm going to ask Calvin Jacobs to do a closing for us. I just wanted to thank you all, thank the panelists from the bottom of my heart. You've touched me, and you've touched all of us today with such passionate and heartwarming stories. And I think we've presented today a different version that has not been completely familiar to McGill and the broader audience. So I thank you and congratulate you for the wonderful work that you are doing. And I will pass it over to Calvin to do a closing for us. And thank you all again, Nakumik.
So onagadiwahi gajokwa as wadon siost ganigani wesa. So once again, I'd like to thank everybody for joining us this evening. I think it was, I learned a lot myself. I thank the speakers. But in the beginning, what I did is I put our minds together as ones. I send our greetings and thanks to the Creator for all the gifts of the natural world. And so now our time has come to an end. And so what I do is I separate our minds so that we can go back to the place where we came from. So that when we leave from here, where you are, and if you have to travel, and no harm will come to you, you will not stumble. When you get home, your family will be waiting for you with open arms, and they'll say, "Oh, wagatsanuni, kanarunkwa." We're so happy and we love you that you made it home safely. So everybody can close their eyes for a minute, and I'll do what we call separating our minds. Onagadiwahi gajokwa was wadon siost ganigani wesa. Ona ne numa ne on de huerdege. Ayum katon konta kwene gayenyu wedege radi riakerono. Ne gadi ne ona ne on de huerdege ne gajokwa gwego. Ne onze wata de wat nione. Ne onska kujungo ngwahni gora onzi de jungo. Ne gadi nyori wagadari watkweni zina hoda kariwaya dakwa. Eto gadi na eto ganeso watni gora. Ona gadi agwego. On do wadu yandu. On de wahorga ne gwatni gora. Dano that's it the one warado ne songwaya dizunzina hoda songwasaani zihunzade. Eto gadi na eto ganeso watni gora. Ona gadi nuwa wanisarade wade wadari one hodum. Nyawa ze wagwego da nyawa songwaya dizo. Eto gadi na eto ganeso watni gora. Dana ona eto. So I thank everybody.
Oh.
And I wish you nyawa. I say nyawa dano ze wadara swiyahak. Eto gadi.
Thank you. Thank you very much. Good evening. Bonne soirée to everybody. Thank you very